presentation. This week it is on headaches. I'm very happy to say that I'm being joined once again by Dr. Anas Ali Syed, and we will be taking on what is actually quite a worrying topic for a lot of juniors, because headaches can, they range from, very mild, not really a serious issue, to actually something that's quite scary, and above our pay grade really to be managing. But before we start, I just need to tell you a little bit about our sponsor, who you've probably heard about before if you've been on these webinars before. So it's called CPD.me, and this is a website that you can go onto. You can watch lots and lots of webinars. They're all CPD accredited, so you can put it in your portfolio. And that's for doctors, but also for nurses or anyone that needs to develop a professional portfolio. And it's for only £8 a year, thanks to the 50% discount you get using this QR code here. And I will post it later in the Facebook group for you to have a look at. But now it is my absolute pleasure to hand over to Dr. Syed, who is a consultant pediatrician in general pediatrics, and joined us a couple of weeks ago for a very informative talk all about rashes. So over to you, Dr. Syed.
Thank you. I'm Dr. Syed, consultant pediatrician here at Stoke Mandeville Hospital, which is in Buckinghamshire, England. And the topic of today's discussion is headache, which is the second most common symptom after fever in children. And considering the current availability of information on Google everywhere, it gives lots of anxiety to the parents as well as to the doctors. And usually, if the presentation by a patient is headache, at the end of consultation, many times doctor is having more headache than patient itself. So this approach is a little simplified. It's a huge topic. Many books are written on headache. So in this brief presentation, little guidance how to approach a child with headache. So half of the children experience one or more episodes of headache by 7 years of age. Most of the children experience headache by 15 years. So you can say by 15 years, every child knows what headache is. 25% of adolescents suffer from weekly headaches, resulting in school absence and reduction in quality of life. And headache is one of the most frequently reported illness in 10 to 24 years age group. Headache is a benign symptom. Majority of patients is self-resolving and no underlying cause is detected. Sometimes it may be a manifestation of serious illness like meningitis, brain tumor, or intracranial hemorrhage. In emergency setting, like patient is brought middle of the night to hospital, 5% of patients have a serious neurological cause, and where it is very important that patient should be assessed very carefully and a rapid diagnosis is made. So starting with simple pathophysiology of headache, from where this headache is coming, is that pain in the brain? If you look at brain, the source of pain, the brain parenchyma, its epidermal linings and are all insensitive to pain. All meninges except dura are also insensitive to pain. Headache is due to stimulation of pain receptors outside the actual brain substance. Now, what are the pain sensitive structures in the head and neck? In intracranial, cerebral and dural arteries, large veins and venous sinuses, dura mater at the base of brain. So these three structures are sensitive to pain. The pain sensitive structure in the head and neck extracranial nerves and cervical roots, extracranial arteries, scalp and muscles attached to skull, paranasal sinuses and middle ear, periosteum and teeth. Now, mechanism of pain production. Dilatation of intra or extracranial arteries, traction, displacement of intracranial arteries and large veins or their dural envelopes by a space-occupying lesions, compression, traction or inflammation of cranial or spinal nerve roots, spasm, inflammation or trauma to cranial nerves or cervical muscles, meningeal irritation, raised intraocular pressure, or inappropriate activation of brainstem or cranial nerves. The example for brainstem is migraine, and for cranial nerves is trigeminal neuralgia. Now, the location of headache, as the pain sensitive structures are more vascular related, so we have to see where is what blood vessel and what is the nerve supply of that. So this is the supply of brain. Anterior cerebral artery is supplying at the superior area of the brain, while the middle cerebral artery is supplying most of the external or lateral surface of brain, and inferior cerebral artery is supplying the inferior surface of brain. If you look from inside, so this is the supply. The blue one is anterior cerebral, the red one is middle cerebral, very little part of inside the brain substance is supplied, and the green one is the inferior cerebral artery. Now, nerve supply of the pain sensitive structure. In the intracranial structures, in the supratentorial vessel, trigeminal nerve is the nerve supply. There are three divisions. Division one is ophthalmic, second is maxillary, third is mandibular. So all three are supplying supratentorial vessels of the brain, while the infratentorial vessel, which is in the posterior part of brain, are supplied by cervical nerves 1, 2, and 3. So if we locate the nerve supply to the surface of head, so this is the area where the pain will be referred. So V1 is the first division of trigeminal nerve, like ophthalmic division. V2 is the maxillary division, and V3 is the mandibular division, while back of the head and neck is supplied by cervical nerve roots. Now, classification of headache. The primary headache is there is no underlying cause. Most common is the tension headache, which is 69%. Migraine is 16%. Idiopathic stabbing, one type of sharp headache, is 2%. Cluster headache is only 0.1%, while exertional headache is 1%. While secondary headache, where there is underlying structure or infection, so systemic infection causes 63%, head injury may cause 4%, vascular disorder can cause 1%, subarachnoid hemorrhage less than 1%, and brain tumor 0.1%. Approach to diagnosis. So like all the medical condition, the approach is with history, physical examination, and investigation. But in headache, history is the most important, because whatever the physical examination and investigation are, mostly these are unremarkable. So you don't find any fault in physical examination and investigation. So a carefully taken history can help a lot to find a cause. So in history, most important is age of onset. We have to remember that migraine headache usually begins under 10 years of age. A tension headache is issue with adolescent in children population, of course. And mode of onset, abrupt onset of severe headache or thunderclap headache may mean some intracranial pathology. And if this is worst headache of life, may mean intracranial hemorrhage even. So acute onset headache, which was never before, must be taken very seriously. Frequency of episodes. So cluster headache comes 2 to 3 times a day for months, while migraine may have 2 to 4 episodes in full 1 month. Tension headache could be few days a week or all days of week. Duration of episode. Cluster headache duration is 5 to 15 minutes but may last up to 1 hour. Migraine may last 1 to 3 hours but sometimes may go up to 2 to 3 days even. Tension headache may last whole day. Time of episode. So when headache starts in lying down position or sleep or early morning, it points towards raised intracranial pressure, that means intracranial pathology. Late morning hours headache is usually from frontal sinusitis or other sinus infections. And late during day is tension headache. Preceding events. Any aura or prodrome is a feature of classical migraine, or any history of trauma to head could be the cause of headache. The quality of headache has some clue in diagnosis like throbbing, pulsating, hammering, most common in migraine, squeezing headache in tension, aching or deep continuous headache in cluster headache. Location. So localized headaches usually suggest a local pathology like sinusitis, otitis media, or dental abscess have a local headache. Bifrontal or bitemporal headache is most likely in migraine. Retroorbital or temporal headache will be in cluster headaches. And occipital headache means posterior cranial fossa pathology or basilar migraine. Triggering factor. Posture, activity, lack of sleep, exertion, food, bright lights, noise, menstrual period, all can trigger the headache. And posture is more related with the intracranial pathologies. If more headache in lying down or during exertion, it could be pointing towards raised intracranial pressure. Relieving factor like rest and sleep in dark room, most common in migraine, or sleep can relieve a tension headache. Similarly, analgesia, medication, and oxygen can help the cluster headache. Relationship with other activity. School problem, change of school can lead to tension headache. Recent changes in sleep, exercise, or diet can lead to headache. Recent changes in growth or vision can be because of pituitary tumors, craniopharyngioma, or benign intracranial hypertension. Associated symptoms. Fever, neck pain, pallor, vomiting, diplopia, dizziness, all these point out towards infections or intracranial pathologies. Psychosocial issues can lead to tension headache, and family history is very, very important in migraine. Majority of children who will have migraine will have a positive family history. So this is a good clue towards diagnosis. Detail of a typical episode is just like similar all the features, but we have to remember that headache may be two types. Like a person has migraine, may have a headache because of intracranial pathology. So sometimes child will present two different types of headache. So we need to know what is the more typical and more frequent type of headache so that you can make diagnosis. The physical examination should be very thorough. General appearance, skin examination, vital sign, checking for blood pressure, growth parameters, including head circumference in children, examination of eyes, ENT, teeth, temporomandibular joint, spine, palpation, auscultation of head and eyes for any bruit, complete neurological examination including fundoscopy, and checking for sign of any meningeal irritation. Now, after going through history and examination, we should make up our mind that what type of headache we are facing. And this step is very important for helping you to make a diagnosis. So after going through history and examination, you decide among yourself what sort of headache you are facing, because headaches can be only 4 types. So we are just on a crossroad that which way we have to go. Is it acute or new onset headache? Then the causes are different. If it is acute headache but recurrent, many similar episodes before, then causes could be different. If it is chronic and non-progressive headache, means same headache going on for weeks and weeks, it may mean different type of headache. And if it is chronic and progressive, it may mean a different group of headaches. So we have to categorize our patient into one of these to proceed further towards diagnosis. So acute headache. So systemic infections, any fever, any infection, malaria, throat infection, pneumonia can cause headache. Intracranial infections can cause headache. Trauma to the head can cause acute headache, never before. Intracranial hemorrhage can cause headache. Hypertension, crisis, person can have a headache. Sinusitis, otitis media can have a headache. Dental abscess can lead to headache. Eye problem can lead to headache. Toxins like drugs and carbon monoxide poisoning can lead to headache. Acute but recurrent headaches. So when headache is acute and quite severe, but there are many episodes in the past. So most common is migraine, then could be cluster headache, or could be a seizure headache, where a person may have actually seizure episode, but clinically complain only of headache, which is a post-ictal feature in many cases. Now, a little bit about prevalence of migraine. In first 12 years of age, the migraine is almost equal in boys and girls. But as the age advances, the prevalence of migraine become more and more common in females. So at the peak of adolescence, it is almost double than male episodes of migraine. Now there are clinical types of migraine. Migraine with aura, which is called classical migraine. Migraine without aura, which is called common migraine. And there are other conditions which have been grouped under migraine equivalents. So these are associated with transitory neurological dysfunction as well, like acute confusional migraine, basilar migraine, benign paroxysmal vertigo, cyclical vomiting, hemiplegic and ophthalmoplegic migraine, where a person look like having a stroke, but actually it is basically a migraine episode. Transient global amnesia or paroxysmal torticollis. All this could be a presentation of migraine. Now the diagnostic criteria International Headache Society has made for pediatric migraine without aura. 5 or more episodes of headache lasting 1 to 72 hours, separated by symptom-free interval. So it's very important, in between the episode, person is free of headache. If it is daily headache, it is not migraine. At least 2 of these features are associated, like unilateral or bilateral pain, like one side of head or both sides of head, pain of throbbing nature, moderate or severe pain aggravated by activity. So if a person has acute migraine episode, routine activity has to be suspended, otherwise headache can become more unbearable. Then associated symptoms are nausea or vomiting, or photophobia or phonophobia. at least one of these symptoms. Cluster headache. This is a headache which can be mixed up with migraine, although it is much less common than migraine, but many features are similar. But still, if you take history carefully, you can always discriminate. Cluster headache recur over a period of weeks or months, separated by interval of years. So the headache will be almost daily for a period, then it will go away and may come back after months. Onset after 10 years of age. So while migraine is before 10 years. Migraine is more common in female, this is more common in male. The family history is classically negative in cluster headache. Headache often begins during sleep, occurs in bursts lasting 15 to 60 minutes, and repeats 2 to 6 times each day. Usually starts behind and around the eyes and then become hemicranial, and always recur on the same side of head in subsequent attack. So cluster headache will come only on right side or left side, while migraine can come on both sides or alternate. During the attack, in case of cluster headache, person cannot stay still. He will be very restless, walking around, and putting him in a dark room peacefully will not give him relief. So this is how you can discriminate it from migraine. Nausea and vomiting is not there in cluster headache. Scalp may be tender or edematous. Ipsilateral hemicranial autonomic dysfunction could be there. No much relief from common analgesics. Somatriptan and oxygen inhalation can treat an acute attack. And recurrence can be prevented by prednisolone. So there are a good bit of features which are similar, but many are quite different than migraine, and one can easily discriminate. The third group is chronic but non-progressive headache. Same headache for ongoing for months and weeks altogether. So most common is tension headache. The next is post-traumatic headache. A person has head injury which was significant, that can lead to post-head injury headache which may last for weeks and months. Analgesic rebound headache. Now many people with minor headache are in habit of taking too much painkiller like paracetamol and other, and the day they don't take it, they get a rebound headache. Caffeine headache is also when people are consuming a lot of caffeine, and the day they don't take tea or coffee, they get headache. And similarly, headache is associated with all substance abuses.
I've got a couple of questions here, Dr. Syed.
Yes,
so, Rowan said, great lecture so far, really enjoying it. Is verapamil not used for cluster headache prophylaxis?
Which one?
Verapamil, so a calcium channel blocker.
Yeah, there are many things being tried, but so far no prevention is preferred for cluster headache, because once one spell of attack is over, you don't know, maybe next 2 years there's no headache. So why to take some medicine which has its own side effects?
Okay, thank you. And then Anna asks, would you class headaches that come from eye strain as tension headaches as well?
Usually, it is commonly thought that maybe some error of refraction causing headache. But most of the time, those people who have headache, they come to us after eye testing, and their eyes are normal. So very rarely, a refractive error will cause headache. Very rare.
Okay. Even something like using a tablet all the time, over not so much. Not seeing it as much because of good eye testing in the UK.
Yeah, what I mean that if person has suspicion that his eyesight is causing headache, no harm getting it checked first to clarify, and then try to sort out what sort of headache is.
Yeah.
To be a little more diagnostic approach rather than guessing and treating.
Yeah. Okay. Perfect. Thank you. Both Brian and Anna say thank you very much.
So next is the group which is, sorry, we missed one thing. Oh, one slide it is omitting. How we can go chronic progressive. Is there any other way?
What I can do is I can quickly pull it up here if you like.
No. One slide is Yeah, it's there. So chronic progressive headache. So this headache, although very rare, but there are serious issues attached with it. So when the headache is there and day to day it is getting more and more severe in severity and more added symptoms like nausea or early morning vomiting or headache during sleep, waking up during sleep. So these are few conditions which can cause it, like brain tumors, brain abscesses, benign intracranial hypertension, hydrocephalus, which usually is acquired hydrocephalus, and cerebral vascular malformations. Now, the clinical features which are pointing towards intracranial pathology, which everyone needs to know if he's dealing with children or adults with headache. In history, headache awakening the child from sleep, early morning headache upon waking up, headache worsen in lying down posture, cough, micturition, or defecation. So, whenever there is exertion or in lying down posture, the intracranial pressure increases and that will cause headache. Change in pattern or severity of headache may mean intracranial pathology, and occipital headache may have an intracranial pathology. Clinical features indicating intracranial pathology: age less than 6 years, personality changes, developmental regression. Now, this developmental regression is a red flag for intracranial pathology. And what I mean, those who are not dealing with children, that a child was running around, he stopped running and walking carefully. A child who was walking stops walking and starts crawling only. And a child who was sitting stops sitting and lying down. So that is a serious indicator of intracranial pathology. And if we consider that just a developmental regression, not intracranial pathology, you may be late in diagnosis. And I've seen people diagnose children very late because they ignored this developmental regression. So this is a very, very important physical sign. Abnormal growth, too much fast growth, early pubertal development, headache duration in less than 6 months. If it is acute, recent headache, need to be explored. Absence of family history of migraine. When a person presents with something resemble like migraine, but there's no family history, it should be taken more seriously. Clinical features indicating intracranial pathology: coexisting medical condition like immune deficiency, coagulopathy, congenital heart diseases with right to left shunt, sickle cell disease, polycythemia, malignancy or past history of malignancy. So even if malignancy is declared cured, maybe after a couple of years, person may have headache and actually it is a newly growing secondary. It can happen. Clinical feature indicating intracranial pathology among physical examination: abnormal neurological examination like ataxia, weakness, focal sign, very serious. Diplopia, abnormal eye movements, papilledema, retinal hemorrhage, cranial broods, then neurocutaneous syndrome. All these points towards intracranial pathology. Miscellaneous headaches. So this is a group which is not coming in any group. Connective disorder can lead to headache. Metabolic disorder can lead to headache. Hypoxia, hypercapnia can lead to headache. Dialysis, those who are on long-term dialysis, they can have headache. Those who have lumbar puncture or intrathecal injection, they have post-procedure headache for days. And neuralgia or trigeminal neuralgia. Investigation. So these are the basic investigation we do. But although a person who comes with a headache, he has a mind to get a scan done of head. So let's see where scan is urgently indicated. So these are urgent indication that we must do scan immediately. The first is worst headache of life or thunderclaps headache. where a person has never experienced headache and suddenly ended up in emergency that he has very, very severe headache. So that child should be taken or adult should be taken seriously because yield of intracranial pathology is up to 5% in such cases. Sudden onset of new severe headache, headache increasing in severity and frequency, recurrent early morning headache, frequent awakening due to headache, occipital headache, increased pain with straining, coughing, then abnormal neurological signs, reduced visual acuity, change in growth rate, developmental regression, or recent change in behavior. So all these are indication for a quick brain scan. So now we come to the management. So I'll go to just briefly only. So first thing is secondary headache. That means some underlying cause. So we have to trace a cause, what is causing this headache. And once we treat the cause, headache will go away. Now comes next one is the primary headache, where there is no underlying cause. So that means cluster headache or migraine. So here the treatment is pharmacological therapy, which is two forms. One is treating acute attack in the form of abortive therapy, and one is prophylactic if the attacks are recurrent. And then comes the psychological support for a headache. Then pain management techniques can also help, and behavioral therapy can also help. So let's see quickly how we treat an acute attack. So general measure for abortive therapy are education of child and family, how to deal with an acute attack, keeping a diary of attacks, precipitating factors should be identified like stress, poor sleep, specific foods, weather changes, menstrual periods. Then resting in dark, quiet room with a cool cloth applied to the forehead is helpful. The medication which can be helpful in acute attack of migraine are paracetamol and brufen. And luckily, most of the children with migraine can be treated this way. Rarely they need, attack is too distressing that we have to use somatriptan or zolmitriptan. So this can help in aborting an acute attack. So sometimes there is vomiting with every attack. So in those children, there are three available medicines which can help to prevent vomiting. One is chlorperazine, one is metoclopramide, and one is domperidone. Among all of these, the safest is prochlorperazine, popularly known as Stimatil. Now, why this drug is no more popular in our books and literatures? Because company is not making money out of it. So they like people to ignore this. This is the best medicine to prevent vomiting from any intracranial problem, and it is very, very cheap. One tablet may cost a couple of pennies only. So this is safe drug to be used in combination with somatriptan for aborting acute attack of migraine. Then prophylaxis. So it is only indicated if there are more frequent attacks, like 2 or more attacks per month, increasing frequency of attacks, and significant disability despite adequate treatment of acute attack, like somatriptan is not helping, Stimatil is not helping, then we can go for prophylaxis. But it is very rarely required in children. You can say maximally every couple of years we prescribe once some prophylaxis to children. Mostly with treatment they can manage the attack. They learn very well. In adults, certainly prophylaxis is required. So the commonly drugs used for prophylaxis are 3: propranolol, pizotyphine, and topiramate. Out of these, pizotyphine is most commonly used and it is safest. But overall, how much ability of all three to prevent migraine is variable. Some people get benefited, some people not. So no harm trying if it is too frequent, if episodes are too frequent for people certainly they are anxious how to prevent it. Thank you very much.
Okay, wonderful. Thank you very much. So guys, there's a QR code there that you can use it will take you through to where our feedback is. Just after the webinar, I will post in the chat a link to the feedback as well. We really enjoyed having a look at your feedback last time. It was really positive and gave us some things to work on. So please, even if you don't want a certificate for your portfolio, just take a couple of minutes and fill that out for us. In the meantime, did anyone else have any questions? I'm just having a look at the chat on my separate screen here. So if you have any questions, do post them now. Otherwise, I had a question actually about kind of migraines and cluster headaches. With children that suffer from them quite frequently, will they typically persist into adulthood, or is it something that they quite often grow out of?
No, they don't grow out. Mostly, if child is having migraine, he will have it as adolescent and adult.
Okay.
Yeah, it will not go away.
So, Rowan, another question. Thank you very much. Could these slides be shared? Wasn't able to get some of the information. So, one thing that I will be doing is uploading the video recording to both Medal and YouTube within a day. I can also have a look as well. Are you happy for the slides?
Yeah, sure.
Perfect. I can see if there's a way for me to share the slides as well, and I will look into doing that for you, Rowan.
If people are benefited, no problem.
Cool. Perfect. And then Sarah's asked a question. Is there any way to treat migraines that are related to periods?
Yeah, basically, just like management of any acute attack. So certainly period is something we cannot prevent. And the migraine is related with hormonal imbalance. So we have to learn how to manage the attack, and taking medication early is better. If there is vomiting, better to take prochlorperazine or Stimatil. And if attacks are really distressing, then person can take somatropin. Otherwise, mostly paracetamol and brufen are enough.
Perfect, thank you. We've got another question from Kirstine. I hope I'm saying that correctly. I apologise if I'm not. Would you ever give naproxen instead of ibuprofen, or do you never really give it in teenagers?
Yeah, I prefer simple ibuprofen and paracetamol, because more and more fancy drugs we are using, risk of complication is more and more. And one thing I want to share, that my mother developed rash because of naproxen, and that killed her. How? Because she was mildly diabetic, somebody prescribed him steroids, and she got stomach perforation. So that unnecessary to use fancy medication, because companies promote a lot of analgesics. I feel you stay with paracetamol and ibuprofen because it is extensively used and time tested.
Perfect, thank you. And then Yvonne is asking, can we share the 2-week rules for GPs? Yeah, same goes for that. I can see if I can get that uploaded for you. Anna then asks, are there any headaches that are more typical if a child was born prematurely?
And then no particular related to the prematurity. Yeah, no specific label for prematures to have particular type of headache.
Okay, perfect. Thank you very much. Thank you everyone for your questions. If you do have any further questions, you can always post it on the Facebook group, or even send an email to paediatrics@mindthebleep.com. As I said, I will make sure that the video of this goes onto Medal tonight, and then probably YouTube. It normally takes a day or so to upload it, but look out for it there, and we normally share it on our social media. Thank you very much once again. It's an absolute pleasure, and I definitely learned a lot. So let me see if I can.
It is a little dry topic, but it's very important.
Oh,